Yes, I do have an interest in pregnancy and IBD, but currently I am pregnant, but I will not be talking about pregnancy in this situation. But I am very excited to talk to you about changing demographics of surgical IBD patients. I have no disclosures. So as Justin pointed out, our armamentarium for IBD therapy has drastically increased over the past 2 decades. And so in this context, I will be talking about the rates and trends of colectomy and ulcerative colitis, as well as intestinal resections and Crohn's disease. I'll also share with you data on obesity and the surgical IBD patient. So we'll start with ulcerative colitis. So over the past few decades, actually dating back to the 1950s, colectomy rates have been described. And between the 1950s and the 1980s, the colectomy rate for patients who are 5 years post-UC diagnosis were as high as 35% in patients with extensive disease. In the early 1990s, there seemed to be a shift in colectomy rates, and 10 years post-diagnosis was reported to be as low as 10%. So what might be the reason for this change? Well, interestingly, this is around the time that azathioprine began to be used. This is a Kaplan-Meier estimate of the cumulative probability of colectomy in ulcerative colitis. This data comes from a Danish cohort of patients with ulcerative colitis diagnosed between 1979 and 2011. And you can see that there's a decrease in colectomy rate around the time of the immunomodulator therapy era, as well as early anti-TNF era. So looking at this, there seems to be some compelling evidence that perhaps the beginning of the immunomodulator and anti-TNF era seemed to contribute to decreased colectomy rates in ulcerative colitis. But when you look at things a little bit in greater detail, things start to fall apart. So in this Danish cohort, the author specifically looked at patients who were currently using azathioprine compared to those who had never used azathioprine. And interestingly, they found that patients on azathioprine actually had a higher incidence of colectomy. So a potential explanation could be that sicker patients were on azathioprine and so eventually required surgery, but it was just that requirement was delayed compared to patients who were not who were diagnosed prior to the availability of azathioprine. So maybe it's not better medications that are leading to decreased colectomy rates. So this data comes from a Canadian study that stratified colectomy rates based on era of diagnosis. And if you look at the red and blue cohorts, you can see that there's a decrease in colectomy rates even before immunomodulator therapy became very popular, especially in Canada. And so what might be a potential explanation for this? Well, perhaps we're performing colectomies at an earlier time to diagnosis. And then also you have to keep in mind that this is the time when access to colonoscopies became greater and there's a greater awareness of inflammatory bowel disease. And so patients were being diagnosed with milder disease earlier on, and these patients didn't require surgery at all. So let's talk about the biologic era. The data here is actually pretty mixed depending on which cohort you look at. So if you look at the left figure here, this comes from 1,200 ulcerative colitis patients in Switzerland, and this specifically refers to the biologic era between 2005 and 2015. And you can see that clearly the colectomy rate is decreasing during that time frame. And also I want to mention that the authors in this particular study did note that there was a decrease in colectomy that there was colectomies were being performed earlier in the disease course after 2003 compared to before 2003, which supports one of the possible explanations that I presented in the previous slide. So looking at the U.S. data, this comes from 58,000 ulcerative colitis patients using the Truven Market Scan data, which is a health claims data that covers both private and public insurance claims. And this is interesting data that shows that, well, as expected, the rate of infliximab use goes up over the course of the study. But interestingly, colectomy rates also increased. And again, this is 470,000 hospitalizations for ulcerative colitis. So this actually goes against the idea that biologics lead to decreased colectomy rates. So what if we look at the data further and look at elective versus emergent colectomies? And again, the data here is mixed, but the devil is in the details. So the left figure here, it comes from Canada. And they looked at ulcerative colitis patients between 1997 and 2009, and they found that the rates of emergency colectomies were actually stable over that time period compared to elective colectomies that were actually that decreased during that time frame, then leading to an overall decrease in colectomy rate. So why are emergent colectomies staying stable? Well, as I said, the devil is in the details. If you look at the study follow-up time, it's up to 2009, and infliximab was not approved in Canada until 2007. So perhaps this doesn't actually accurately reflect the impact of biologic therapy on colectomy rates. Now let's look at the U.S. data on the right. So this comes from the National Inpatient Sample that examined hundreds of thousands of patients with ulcerative colitis. And here there's a clear trend for a decrease in emergent colectomy rates with stability in non-emergent colectomies. And so to be perfectly honest, I do believe this data a little bit more just because the U.S. data looked to the year 2015, which was well into the biologic era. Another really interesting trend in surgeries is that there's a greater shift towards restorative proctocolectomy in a staged fashion, as opposed to a one stage kind of thing. As opposed to a one-time colectomy. So this data comes from nationwide inpatient sample database as well. This time involving 1.5 million ulcerative colitis admissions between 1991 and 2011. And you can see here, so the dotted line refers to 2005, which is when infliximab was used in the U.S. for ulcerative colitis. And you can see that there's a greater, there's a big increase in total abdominal colectomies as well as separate pouch surgeries. And again, during that time frame, you can see that total abdominal colectomy without proctectomy actually superseded total proctocolectomy with or without pouch. And similarly, pouch without total abdominal colectomy superseded rates of total abdominal colectomy with pouch. And again, this very nicely coincides with the use of infliximab. So what are some possible implications? Well, maybe patients are more ill at the time of initial operation, so we're more comfortable doing a staged procedure. Maybe there is a surgeon-perceived bias of increased surgical risk, or maybe we have more specialized surgeons that focus on pouch construction. So let's move on to surgery in Crohn's disease. So according to the Rochester Epidemiology Project, there's really been no difference in terms of surgical resection rates for Crohn's disease. And these cohorts are broken up by time of diagnosis between 1970 and 2004. Again, devil's in the details. The study here goes up to 2004, which is actually prior to the biologic era. And why is this important? Well, actually, I would say there's a greater role for immunomodulator and biologic therapy for Crohn's disease patients compared to ulcerative colitis patients. 5-ASAs are actually not approved for Crohn's disease patients, and so a greater majority of our Crohn's patients are on immunomodulators and biologic therapies. And so perhaps there's a greater impact of these medications on surgical rates. And that actually has been proven to be true. Going back to the Danish cohort that I mentioned earlier, you can see that there's a larger gap in the Crohn's population than in the ulcerative colitis population right around the mid-1990s when immunomodulators were being used, and then subsequently biologics were introduced as well. And then, again, looking at a Canadian study, you can see that there's a beautiful trend of decrease of emergency surgeries in Crohn's disease and an increase in elective surgeries in Crohn's disease. And this is, again, referring to the biologic era. And again, along the same thread of thought, emergency stoma rates decreased compared to a stable rate of non-emergent stoma rates in Crohn's disease. So shifting gears, I do want to mention obesity in the IBD adult patient. The incidence and prevalence of obesity and IBD are both rising separately and together. And in fact, more than a third of the US population is considered obese. And the incidence of IBD has been increasing at a nearly exponential rate as well. And so there's greater overlap between the two. And in fact, there is some literature, it's pretty convincing to support that perhaps obesity is actually a risk factor for development of de novo inflammatory bowel disease. So this is something that we're seeing in our patients, and unfortunately, it's not going away. And so this poses a particular surgical challenge because, especially in the setting of pouch creation. Mesenteric fat decreases the length of bowel, and so there may be less bowel to reach the pelvic floor when trying to attach the pouch to the pelvic floor. Also, a larger abdominal wall is associated with greater stoma retraction, and there has been literature to support that patients with inflammatory bowel disease who are obese have higher output volume, prolapse, necrosis, skin irritation, and retraction. Also, there's data to support that patients who have IBD and who are obese have longer operating times and are at increased risk of pelvic sepsis. So in conclusion, in ulcerative colitis, colectomy rates did begin to decrease even before immunomodulator and biologic therapy. Reports of colectomy rates for ulcerative colitis in the biologic era have been mixed. And then data on the association between immunomodulator and biologics and colectomy rates is actually pretty unclear when it comes to ulcerative colitis. And then staged colectomies for hospitalized UC patients have been more popular in the biologic era. And then when it comes to Crohn's disease, annual surgical rates were stable before the biologic era, but actually convincingly did decline in the post-biologic era. Emergent ostomy rates for Crohn's disease declined in the post-biologic era as well. And then regarding obesity, the prevalence of obesity and IBD has certainly increased. And this poses technical challenges for the IBD surgeon. That's it.
Thank you, Dr. Shmidt. I just want to take the privilege of the chair desk, just a couple questions. The first is, with these, with the biologics, and contemplating a colectomy or surgical intervention, how much do I need to worry about time since their last infusion? Do I need to wait kind of for a washout? Is there anything new on that, or do I have to kind of wait the traditional 6 weeks? And what should I tell the patient about surgical complications when they have one or more agents on board?
All right, well, that's kind of a big question. When you look at the literature, there's a study that was recently released by Ben Cohen. It's called the Puccini trial. And they found that exposure to biologics prior to surgery within 12 weeks of the surgery did not lead to any complications. Honestly, that's not really, doesn't blow anything out of the water, because 12 weeks is a pretty liberal amount of time, right? I would say that practice is you wait about 4 weeks prior to surgical resection and 4 weeks after surgical resection to restart biologic therapy. And there isn't really convincing data that suggests that beyond that, there's a benefit to wait, because you really want to make sure that the disease is well controlled going into the surgery, or as well controlled as it possibly can be, and that you're decreasing recurrence rates. There also has been some data recently on increased risk of pouch complications in patients who have been exposed to biologic therapies. I will say that you have to take all of that with a grain of salt. I mean, in a way, who doesn't get exposed to biologic therapies prior to pouch formation, right? And those are the sick patients that are, probably more likely to be at increased risk in the first place. So it's clear as mud.
Yeah. Thank you. Thanks so much.